Thank you, Dirk, and very nice talk, Koen. I think it's important for us to realize that till this day, we still have no good solution for a very common problem of a 14 or 15 centimeter BTK lesion. So this talk was a proof of concept that tickled the mind. So this study was conducted in Singapore. These are my disclosures. So what are the current unmet needs for BTK? Well, one of them, as we saw in some of the cases, was recoil and calcium, as well as clinically relevant restenosis. The other things we can, in a sense, handle. We can do direct angiosome-related angioplasty, retrograde. There's no real CTO these days if you can do a retrograde puncture. But still, restenosis and recoil remains a very major problem for us. The early experience with Ramon Vaca with a bioabsorbable stent was published in this series. It was a proof of concept where they managed to look at restenosis and wound healing, and subsequently we decided to embark on a trial which is called the DISAPEAR trial, which stands for drug-impregnated stent in Asian population extremity arterial revascularization, quite a mouthful. Anyway, this is a physician-initiated prospective registry of the bioabsorbable stent from Abbott, the BVS, and the primary outcomes were vessel patency, target lesion revascularization, limb salvage rates. And at the same time, simultaneously running along with this study, we did a dedicated duplex ultrasound, CT angiography, as well as an MRA angiography to delineate the patency of these stents. It was a small cohort, about 28 patients of registry, 90% diabetic, 100% with CLI, with majority in Rutherford 5 or 6, with very few rest pains. We implanted 50 BVS in 31 lesions, 22% were occlusions. The length, the lesions, most of them were in the anterior tibial artery, as well as the short lesion in the tibial peroneal trunk. The median length of the lesion was 28 millimeters, but ranged from 18 to 102 millimeters. And median vessel diameter was about 2.5 millimeters, ranging from 2.5 to 3.5. A case example that we had, a patient like that, pretty similar to what PK had, except that it wasn't occlusion. This is a stenosis. This patient was treated with bioabsorbable stent after sufficient pre-dilatation and adequate vessel sizing in a patient with a pretty disastrous looking, not much of a foot left. But essentially, at 4 months, with improved vessel patency and good wound care, we managed to get the patient to heal subsequently. Another patient with Rutherford 6 gangrene, and this patient has severe gangrene. In this case, we revascularized all 3 vessels, but we applied the bioabsorbable stent to the shortest looking vessel, which is a peroneal artery. And this patient was treated with 2 2.5 and 1 3 millimeter bioabsorbable stents. And then this was the post result. And at 1 year following imaging, you can see both the anterior tibial and posterior tibial arteries that were treated simultaneously to improve perfusion had reoccluded. In addition to that, there were several spot stents put into the anterior tibial as well as the posterior tibial, but the peroneal artery, which was treated with a bioabsorbable stent, remained patent with a biphasic signal at 1 year, helping to keep perfusion to the foot and potentially preventing the next wound. Another patient with a Rutherford 6 gangrene, very deep gangrene with a very eccentric complex lesion in the distal P3 segment, as well as the anterior tibial short occlusions and multifocal stenosis, was treated in a Rutherford 6 heel gangrene, was treated with inflow management with Supera, as well as several bioabsorbable stents stacked up from a proof of concept within the context of a study. We treated and perfused all vessels of the foot as much as we could. 3 years later, in a fairly calcified vessel, the popliteal stent remains open, hopefully because of good outflow. The tibial vessels, which were calcified, were stented with bioabsorbable stent, remained patent with a biphasic dorsalis pedis. This patient, after 3 years, remains walking with no recurrence of wounds. Another patient with the longest follow-up we've had for 4 years, a Rutherford 5 patient with first toe gangrene of 70 millimeters in length. And take note, in 2012, we treated the mid portion of the anterior tibial with 3 bioabsorbable stents totaling 70 millimeters in length. 4 years later, the patient had a recurrence of wound, and we did a control angiogram, and we found that the area that we had stented with the bioabsorbable stent remained pristine, as you can see in this cine shot. What was more interesting for us was the area of the artery above the bioabsorbable stent had actually progressed in terms of disease, as 4 years later, this patient continues to be diabetic. But the area below where we had treated the bioabsorbable stent remained disease-free, and subsequently, because of the size of the wound and the patent flow, we decided not to balloon proximal to the bioabsorbable stent and remove an osteomyelitic toe and had this patient heal in 6 weeks.
On duplex ultrasound and surveillance, you can also see that the bioabsorbable stent actually dissolves. This is on 2012, when we implanted the bioabsorbable stent. In 2016, in the same area, the bioabsorbable stent is no longer visible, except for the markers on CT scan. So these were our preliminary results. It's safe. We had no 30-day MACE or MALE, 100% technical success. Our implantation technique has changed from before. We now do more aggressive vessel preparation and adequate vessel sizing. The primary patency of the bioabsorbable stent was 93, 90, and 87.1% at 1 month, 6 months, as well as 1 year on duplex ultrasound. We had 1 case of stent thrombosis requiring intervention, and this is on our early days. We had a patient on with tuberculosis on anti-tuberculosis medication, which interacted with Plavix. At the same time, this patient had a stent inserted on the distal anterior tibial artery too close to the flexion area of the ankle, and subsequently, this stent thrombosed. Limb salvage was respectable at 6 months. At 6 months was 96.7%. So in summary, we do know that there's good evidence for the treatment of short BTK lesions with conventional metallic stents in the Destiny, Achilles, and Yukon studies. The question is, will this apply to other longer lesions and stents that dissolve away? Now, our early evidence, as well as Dr. Varco's evidence, seems to suggest that bioabsorbable stents offers a similar efficacy as compared to a conventional metallic implant, and even in some long lesions of which are calcified. And certainly, we hope that this may prove to be one possibility to treat a BTK lesion that we don't have a solution for right now. Thank you very much.